this to be self-evident.
That all men are created equal.
As a member of Congress, I get to have a lot of really interesting people in the office, experts on what they're talking about.
This is the podcast
for insights into the issues.
China, bioterrorism, Medicare for all, in-depth discussions.
Breaking it down into simple terms. We hold
these truths. We hold these truths.
With Dan Crenshaw.
The Eagle has landed.
All right, welcome back, everybody. I am really pleased to welcome back a repeat offender. We don't have many repeat offenders, so that's kind of cool. Dr. Bob Kadlec, appreciate you being on the show again.
Congressman, my pleasure. Thanks so much for having me back. It's again, it's a pleasure and an honor to be a repeat offender.
Yeah, and there's a reason you're a repeat offender. So the first time we did an interview, we were doing it on general bioterror threats. We didn't know that coronavirus was coming. And now it's here, so your job got a whole lot busier, didn't it? And explain to the audience what exactly you do for the administration and what your role is.
Sure. My title is Assistant Secretary for Preparedness and Response. It is a function in HHS that has the responsibility to ensure that in a crisis like we're experiencing right now, that we have a unified effort across HHS with all the departments and all the operating divisions like CDC, FDA, as well as across the U.S. federal government with Department of Defense's health assets, the VA, Department of Homeland Security. So unified effort to basically make sure that we can support the American people and state and local authorities.
And on your background, what did you do before this? So you were an Air Force surgeon. You did 5 combat deployments. Where else have you worked? How did you get into this job?
Well, I'm an accidental tourist by all descriptions. I think the key thing here is that I did serve 26 years in the military. Preponderance of that time was in special operations, joint special operations. I did have an opportunity to make several combat deployments as well, but beyond that, I ended up working in the Senate on 2 occasions. One on the HELP Committee, Health, Education, Labor, and Pension Committee, as a staff director for the Subcommittee on Bioterrorism and Public Health Preparedness back in 05-06. And then again in the Senate Intelligence Committee prior to taking this position in 2015 to 2017.
Well, we appreciate your service. And did you do anything special for Memorial Day?
Well, you know, it is a very special occasion. Typically, I go to Arlington. That was closed. There's several colleagues, as you probably have, who are interred there. And without having that benefit, certainly had a few quiet moments to myself and think about the many individuals that I had the pleasure of knowing and serving with, particularly in the first Gulf War. Probably the greatest combat American loss was Spirit 03, which was the AC-130 gunship that got shot down. The command pilot was a classmate of mine from the academy, and the 14 other people on the aircraft were friends, people I played softball, soccer with, took care of their families. So that, along with more recent events in Iraq and Afghanistan, there are a number of others. So it is a solemn occasion.
It certainly is. And it sounds like your daughter or she's training to join the Marines. Is that?
That's it.
All right.
So
how old is she?
She's 20. She's intending to go to officer training school, and despite my best arguments, she wants to be one of the tough, the proud, the Marines.
Awesome.
It is awesome.
Yeah, they must be proud. Okay, so let's get into what you do now as an ASPR, and that's it's an interesting acronym. It's Assistant Secretary for, I can't even remember.
Preparedness and Response.
Preparedness and Response. And it plays a crucial role in the coronavirus response. So give us an overview of, from day one, what you guys were doing.
Sure. Well, beginning back in January, when we first heard the news of this, clearly Secretary Azar and CDC and the rest of us were very concerned about what was being reported. And what was being reported was fragmentary. It wasn't complete. We can look at a lot of reasons why, but I think the key thing is we had a deep suspicion that something significant was going on based on 2 factors. One was maybe what the Chinese were not reporting, but 2, what they were doing. They were doing extraordinary things to limit the movement, quarantining, isolating people, cities of 11 million. Mm-hmm. And by the mid-January, it was evident that there was something of significance. There was no formal acknowledgement that there was person-to-person spread, but we had set up task force within my organization to look at medical countermeasures, whether we had therapeutics, vaccines, and diagnostics. Quite frankly, this was kind of a very disturbing scenario because much of our planning historically had been focused on pandemic influenza, which we felt was the more likely scenario back to 2005 and 6, when I was working in the HELP committee. That was the principal concern of the nation then. But one of the things that transpired is that we developed, vaccines for influenza, therapeutics, antivirals for influenza, and diagnostics for influenza. And lo and behold, we had none of that for this particular novel coronavirus. So that was a major focus and thrust in January, as was healthcare resilience. How is our hospitals going to basically manage this? And then what about supply chain? For 10 years, quite frankly, the Strategic National Stockpile, which is the principal element where we keep a lot of materials like personal protective equipment or PPE, there had flat funding, and quite frankly, we had very little means to basically expand the stock, the holdings of that. So we were already beginning the planning to say, what would we need to buy? What would we need to do? How do we need to prepare for this? And how do we basically transmit this to the health system, which I know in Texas, where you come from, is a major asset and contributor, heroes in every community. But obviously, knowing that this is going to be a major impact on our healthcare system, and how do we prepare for that? How do we tell the hospitals, how do we tell healthcare workers, what do they need to do to prepare? So that was already starting in January, and then February, it became evident that this was going to be something really significant. And this is, I think, where the president made a big move, gutsy move, to basically stop travel from China.
Right, because they cut off, like you said, all this internal travel. They'd locked down cities, but they were still allowing people to leave the country, which we still haven't figured out why they would do that.
Well, I think it was the economics for them that they drove that. But the point being is the president said stop, and we did. We were involved in ASPR. Again, we don't get a lot of notoriety, and we're not looking for notoriety. I don't see us as show horses. We're workhorses. Our job is to basically do the tough missions that had to be done, and one of those was actually repatriating all those Americans out of Wuhan.
So, but we never hear about ASPR. We never hear about actually what goes on at this division within HHS. We hear from Dr. Fauci and Dr. Birx. So how do you work with them? Who does what?
So I'm part of the White House Task Force. I was one of the original members of that, participate in the meetings. Our role is really on the functional operational side. There's a strategy and, if you will, external communications. I don't think there's anyone more trusted in a name or a brand than Dr. Fauci and Ambassador Birx, who has an extraordinary history in working with HIV and again has great notoriety. And so those are the people who really need to basically talk to the American people, be the trusted face and a steady voice to everyone. And for me, I'm kind of like behind the curtains, working hard, working with a great team of people. And again, our team is not only in HHS, but DOD and VA. And also we're working to support state and local authorities. And
your authority comes from a bill that is passed every 5 years, it looks like. It's called the PAPA, or the Pandemic All Hazard Preparedness Act. That was last passed in June 2019. So how does that dictate what we should do? And is that what was driving us towards more of an influenza-based response?
Well, I think the original PAPA was based on, from 2005 and 6, when we wrote the original inaugural draft of that, was really focused on the experience of Katrina, an overwhelming catastrophic event, and overlaying that, the risk of pandemic influenza. So those two things, I think, shaded what was the original PAPA, and then through that, it has been refined over time. But one of the areas that, quite frankly, and I think you highlight maybe one of the Achilles heel here a little bit, that flaw in this was, and we recognized it early I guess it was in 2019, was that the worst case scenario may not be the most likely case scenario. In this case, I think with the novel coronavirus, we have the best worst case we could imagine, which is we have a virus that is highly transmissible, which has fairly low virulence and fatality rates for the majority of the population, except if you are old or have some pre-existing condition, and then it could be a death sentence. And then most significantly, there were no vaccines, therapeutics, or diagnostics to manage this. And so this is kind of like, something like out of a synthetic biology kind of novel almost, something that would be very rapidly moving, that quite honestly we had few defenses for other than maybe basic public health interventions like stay at home, wash your hands, cover your cough and sneeze. So that's literally what we were dealing with.
Yeah. So January comes and goes, February comes and goes. It's still not clear to us that at the time that COVID-19 is going to make a huge appearance in the United States. It's not clear in Europe yet by this time either. And so what exactly are we doing to prepare during those times? And is there anything we could have done better?
Well, I think one of the key things is that at the time of February and March, our view was containment. The president made a gutsy call to basically stop travel. It was really the idea that there were maybe a dozen or so, 15 cases of COVID-19 that were imported from China that were identified, and contacts were identified and isolated. We brought back the Americans from Wuhan, the Diamond Princess. We isolated them, quarantined them, and I think everybody felt like those were temporizing methods. There were no way to hermetically seal the United States. You made a great point earlier about, China did not restrict its travel of its people out of China. Mm-hmm. And so one of the major areas that was seeded in Europe, and I didn't know this, it's kind of an interesting story to me, is that a lot of Chinese workers work in Italy, in northern Italy, work in the fashion industry, do the sewing and whatever else. And so there were direct flights from Wuhan to northern Italy. And again, lo and behold, that was where the major outbreak in Europe happened. Yeah. And again, because they had no restrictions for interborder transport, then it moved across Europe. And then I think at that point, it was evident that given that there would be another source of infection seeding the United States from Europe, that the inevitability was, what are we going to do? And here again is one of the challenges within our federal system, right? Some states moved very quickly to basically constrain the movement of their citizens. Some didn't. And the point was it got seeded in the United States and then it started breaking out. And so that's the federal response to that, is supporting what state and locals needed. They needed personal protective equipment. They needed availability of ventilators. And those were things that we really worked very hard on to make sure. And then in mid-March, the response went from containment to basically a national emergency where FEMA basically stepped in, and with their muscle, just to give you some idea of the size difference, FEMA has 10,000 federal workers, 20,000 with their reserve force. ASPR has 800. So they brought a lot of logistical expertise, a lot of muscle, a lot of great relations with the governors. And basically we joined forces, and we had joined forces in January to basically start to work together. We anticipated what could happen, which did happen, which is it shows up on our shores. I think that was an inevitability that everybody understood when looking at what was going in China.
Yeah, I mean, there's a lot of people who said we should have locked down earlier, but I fail to see who would have decided to lock down when you only have maybe a couple hundred cases in the United States. It's a bit of a disingenuous kind of, Monday morning quarterbacking for the most part. So are you guys the ones in charge of, say, figuring out who's going to make the tests? Is there some kind of top level organization on let's get the testing production up and running? Let's get maybe contact tracing, or maybe that really is done at the state level. The vaccine development, does that all occur through ASPR?
Much of it does, and in the current construct with FEMA, there's this unified coordinating group, which represents Pete Gaynor, who's the administrator, myself as one other member, and then Admiral Brett Jouar. And so Admiral Jouar is managing the testing portfolio and how to basically bring that towards ASPR and BARDA. BARDA is the Biomedical Advanced Research Development Authority, which is part of ASPR, which basically does the countermeasures. And a lot of the work that we did was really focus on diagnostics. So we invested in 18 diagnostics. 9 of them have been authorized to be used by the FDA. And we have several million of these tests out there that are both for the testing in hospitals as well as testing in doctors' offices. So we have a hand in it all. And again, in this coordinated fashion, given the scale and scope of this event, we're working together with FEMA on this.
And what's our goal with testing? What's our goal with testing per day, per capita?
Sure.
And because I've become more and more, I think, skeptical of this idea that if you just scream testing enough, that it somehow means that you're solving coronavirus, which is what a lot of people seem to believe. And because, listen, I could have gotten a test yesterday and it's meaningless today because I flew here from Houston to DC. So, it's a point in time. I think there's a reason that in places like Houston, there's way more tests available than people who are willing to go get them, because I think people are smart enough to understand that it's just a snapshot in time. And, if they feel sick, maybe they should just stay home anyway. And really, what's the point of the test? And so, not that they don't have some kind of utility, but I just wonder if we've been talking about it correctly and what your view is on that.
Well, I think you make a great point, is that it is a snapshot in time. And so not everybody needs a test, but there's certain people that should get a test. Because one thing that we've learned about the virus over time is that somewhere up to 50% of the people who are infected with it, who can actually transmit this virus, have no symptoms. So while that may not be, a matter of great concern for the general population, it's a great concern if you work in a nursing home, or if you work in a hospital, or you're, working with people if you're in a cancer clinic, where people who are susceptible to this virus, even though you're not symptomatic, you could spread it. So in the sense of being able to do what I would say discriminatory testing, to basically say, I work in a nursing home, I should be tested how frequently? Maybe not every day, but every other day, to make sure that if I do test positive, and I shouldn't be working in there until I test negative.
Yeah.
And I think that's really where I think we need to focus on. And you're right that from the standpoint is having more tests than people who need the test doesn't answer the problem, but having the right tests for the people who need them is critical.
Yeah, and then what's the right test? Because if it's not an immediate test, you're still in your given role for another day or 2 days, and which is maybe why is it true still that our big commercial labs are still under capacity when it comes to testing?
That's correct.
They're capable of doing far more tests than they're currently receiving, and that seems to be largely because of a lack of demand. If your test results aren't coming back for another couple days, you're just not going to get it. Right. I think a lot of people are thinking that way.
And that's what, within BARDA, the entity in BARDA has been focusing on point of care diagnostics, where you could theoretically use it in a doctor's office, a pharmacy, or in your own home. And to be able to do something, whether it would be blood or saliva, that you could basically test yourself, or do it at a facility like a nursing home, where you could do it in a much more immediate thing. So that's our goal, to do that. We're not quite there yet, but I think the point is that we've made great strides over this. But it just highlights, I think, fundamentally what we need to do as a nation going forward. I think the fact that we didn't have a comprehensive laboratory network where we included public health labs with hospital labs and commercial labs, I think is a real vulnerability. And I think that's one of the maybe silver linings in this event, is that, that's one area that we're going to probably move to going forward.
Right. Well, there was a deregulation that had to happen in February in order for the private labs to go ahead, make the tests. I also hope we learn, I think that we've, as a country, have a lot of lessons learned. We as we would say in the military, we got to do an after actions report.
Yep.
And you don't have to comment on this, but my personal opinion is that we've thought about things drastically wrong with respect to the lockdowns, the length of the lockdowns, with respect to this belief. I mean, we really convinced the American people that tests would save them. And that was never the case. I mean, no doctor ever believed that, but it was yelled from the rooftops constantly, mostly for political purposes. That's the unfortunate truth. Because if there's something there wasn't enough of, then you could blame the president for it. But if we're actually just trying to solve problems here, you've got to be a little bit more strategic about what you're even doing with tests. And you mentioned one way, protect nursing homes. I mean, how much better off would we be if we had simply laser focused on the most vulnerable of the population? I mean, isn't it something like 50% of deaths in the United States? I know this is the case in Texas. 50% of deaths are nursing homes.
Yes.
If you had just focused your resources on nursing homes and not locking down the rest of society, we we'd be in a far different spot. You know, as we speak, Houston is basically totally open. I mean, there's a phase, but people are over it. They're out. And in DC, it's not even close. I don't know how these businesses, and you know what, they voted for their mayor, so there they go. But I don't know how long they're going to survive. Doesn't even seem like opening is an option anytime soon. I'm not sure what their timeline is, but our cases aren't really going up in Houston. Our hospitalizations are actually going down. So there was no real spike. And so it really begs the question about the strategy in the first place. There's arguably more total cases than there was before. So if this is a snapshot in time compared to a snapshot in time in mid-March when there was almost no cases, but we still locked down anyway, there's a logical fallacy here. Like these things can't be true at the same time. And so it really begs the question about whether the entire strategy of heavy horizontal social distancing works as opposed to, say, vertical social distancing. And so what I mean by that is targeted approaches versus a widespread approach. And I don't know, I'm just thinking out loud. I just hope we're thinking about that. And because I don't want us to destroy our economy twice. We've never done this in human history. The entire world did something that was totally unprecedented with lockdowns. And I'm just wondering if that's really how we should be thinking about this going forward.
Well, I think you make a great point about the difference between horizontal and vertical kind of approaches. And I think the issue that we're doing is trying to focus on that vertical approach, where you can actually identify areas that, and potentially within a reasonable amount of time, to identify places that may have an outbreak based on sentinel kind of signals, if you want to call it that. And being able to basically, intervene in those areas and mitigate those events in those areas without affecting other areas.
Right.
And I think, again, it's you can say it was a knee-jerk response. Again, what was, and this is not an excuse, but it is just an explanation, is, again, we didn't know much about the virus.
Yeah.
It is a very pernicious virus, honestly, to think about what it's done. I mean, the belief was, first of all, it wasn't going to affect kids, and now it affects kids in a very, very unique ways that, quite frankly, are confounding.
In which part are you talking about?
This multi-system inflammatory syndrome of children.
Right, but to be fair, what percentage of kids are we talking?
Well,
here?
and that's a good question, because we really don't know the denominator. We do know that in places where there's been a large amount of disease, places like New York and Michigan, there have been a number of cases in these kids, and there have been a few fatalities, which is tragic. But I think part of this is we're learning about this virus continuously. Mm-hmm. That has a neuropathic, meaning it affects the nervous system. It affects the blood system. It affects the GI system. Very novel in terms of what the coronavirus typically does, as well as the respiratory system, which I think has been established with SARS, for example. So we're learning a lot, and as a system of systems, we don't learn evenly. And I think part of this is that people went to, and again, there was a bit of, I'll be honest with you, a little bit of hysteria. And that,
a little bit?
Yeah, okay. I'm good at the understatement. Yeah. But the media did fan the flames a bit by saying, oh my God, this, oh my God, that. And I think, in fairness to our elected officials, so they were trying to do what was right, but in this noise of uncertainty, many people kind of chose the hardest path, the most severe path, which, to your point, is it is the economy and it is our national security that is at risk now, as well as the public health.
Well, it's just not clear to me that it was even the right choice. I don't really care about who's to blame or why they did it. We all sort of did it. What I am questioning now is, given what we know and the data that we do have and how we do understand the virus, it seems a little crazy to me that we would continue along this path. But it seems like we've doubled down, and it's happening anyway. I also had a question about the transmissibility, because does seem, I've seen some differing studies on that. Some that show that asymptomatic transmission is actually much, much lower. If it even happens at all. Have you seen any of these kind of competing studies, and what's your general thoughts? Have we even come to a conclusion on it yet?
Yeah, I just want to capture one thing before we go on to transmissibility, is just to say that I think your point about reevaluating, I think, is one of the issues the president has put out on the table, saying that, whether we have a vaccine or not, we're going to be open for business. Mm-hmm. I mean, you have Mitch Daniels, who runs Indiana University, saying we're going back to school, and other colleges. So I think there's an equilibration that's going on right now, which is good. It's
a natural human thing. I mean, there's a new fear. Everybody engages in some level of hysteria. I just think we've done it to an unprecedented level. Again, never in human history have we done this. We had one crisis, we created two, because I guess two is better than one. But in this case, it's definitely not, though, and that's the problem. And I just hope we've learned our lesson. It's very clear to me that we've not learned our lesson. It's because, I'm still having this debate. Yeah. I'm still watching some, call you a murderer if you want to get back to work. And I just think that's both scientifically wrong and patently insane. And it's never have humans dealt with risk this way. Mm-hmm. And it's funny, like they'll ask a question and the question will go something like, well, and I've been asked this question by a reporter, and I say, yes, we can expect more cases in Texas if we reopen. Well, how many cases is enough for you? Like, what's it worth? What's the number? I was like, what an odd, disingenuous, and bad faith question. You never ask that question about anything else. Let's say we go to war, and we're, and the intent, I would presume, is to win that war. But we're going to go ahead of time and say, as soon as we lose 1,000 troops, we're done. We're throwing up the white flag. We're just done. That's never how it works. Okay, you mitigate risk to the greatest extent possible in order to continue your mission. In this case, our mission is to live, is to keep a society functioning, and to, I think, be open, move into it with both eyes open about the actual costs of the lockdown. And I am sorry, I beat this drum quite a bit. I think in hindsight we've overstepped to a massive extent, especially when the goals that we set out, and maybe you can comment on this, the goals initially that we set forth were to make sure that our hospitals weren't overwhelmed. And that was clearly a goal that was met. I mean, I think very early on across the country, except in New York City, their hospitals were empty to the point where they were being hurt because they weren't getting any income. People were putting off procedures. People have had heart attacks at home because they can't come in. There's been a lot of second and third order effects. And again, this isn't, you guys don't seem to be putting out the guidance here. This is changed from state to state. But why did the goalposts move? And what do you think was the thinking behind a lot of our local leaders to do that?
Well, great question. Series of questions.
We'll get to the transmissibility back to that later.
But I think it relates a little bit of that in terms of understanding what are the risks, the real risks, and not the partial risks. Mm-hmm. And in some ways, I think that was one of the great things. And I think to your point again about this horizontal versus vertical kind of mitigation efforts, that the knee-jerk reaction was horizontal. Mm-hmm. And quite frankly, that's what I think, to your point, has resulted in this, where hospitals were empty, they losing money. I mean, look, HHS gave $100 billion to hospitals just to basically maintain their. That
was the first time. There's more.
Right, there's more coming, right? But I think it's that is the imprecise nature of it, and again, I think a lot of it was driven by fear, some of it unrealized fear. And then it gets to the idea of what science is telling us in terms of what the transmissibility is. Now, I see a variety of things. Here's where and again, there was a lot of focus on modeling, if you recall.
Oh, I recall.
I mean, and
we hear a lot less about the modeling now. Don't we?
Well, I think Governor Cuomo just has a lot of egg on his face over that one. But
and the senior living homes, which he's just not held accountable for. Again, I mean, we won't get into that. It's more of the
But to me, and again, I'll just give you and this is kind of what I used as my guidepost, was, I talked a little bit about the Diamond Princess, where there were a number of people in a Japanese cruise ship, several hundred Americans. What was interesting about that, all of them were tested, and out of the 400 so Americans, only about 20% tested positive, of which 50% those who tested positive, 48% were asymptomatic. Mm-hmm. And these were elderly people. And again, a small percentage of the total number actually ended up in hospital, 10%, and some of those in intensive care.
Yeah.
But those are real numbers.
And did you think that, and you're saying like that Diamond Princess numbers didn't necessarily make it into the modeling correctly?
Because some of the modelings were, so just remember, Diamond Princess was a floating petri dish.
Right.
20% attack
Hard to
rate.
escape each other.
Right. And they were imperfect. I mean, it was like a perfect storm for transmission. But some of the models were saying 50% of people would be, infected and stuff. Yeah. And so a lot of that was driven by, academic, models that,
imagination, academic imagination. Let's put in this number and scare the hell out of everybody.
And,
and that's how models work. You change one parameter.
Exactly.
And the media has this strange incentive, and I know they always have this incentive to make people emotional, and I get it. There's financial incentives there. There's clickbaits. But I just wish they hadn't done the business as usual this time. And I think I just think the costs have been enormous. I yell at the media all the time about how they act because it kind of makes our politics more difficult. But this is beyond making politics more difficult. This had real costs,
real consequences to the American people. You bet.
Because I think we've been driven by fear to an extraordinary degree on this, and every single day, the more we learn, the more I'm convinced of that fact. Again, I was on board with a couple of weeks of lockdowns. I just want to be very clear. I'm still on board with people wearing masks when it makes sense.
Sure.
But that we keep driving down the death rate. By the way, I just saw some other CDC estimates that were exceptionally low. Maybe Megan Stafford can jump in on this. It's like 0.0004. Just 2 zeros, 0.004. That's an exceptionally low death rate in any case.
Right. So, and again, again, that's part of the challenge here is overcoming the psychology of this event. But I think it gets to the other area that I think you've been passionate about is how do we get back to business? How do we reopen?
Yeah.
How do we, and again, I think part of this is really underestimating the intelligence of the American public, right?
Right.
This is common sense, right?
Right.
And people will do common sense things if you give them the alternative.
Right.
And you'll find some outliers. There's always a few outliers out there. But I think the point here is that we have to enable America to get back to business, get back to school, get back to the purpose that we have. This is un-American what we find ourselves into today, right? Cowering in our homes, fearful of our neighbors, and this is not who we are, and this is not the society we want.
Well, it's unprecedented. It is not who we are. And as you mentioned, trusting the intelligence of the American people, they understand the risks by now. They're educated on them. They can be trusted to take the precautions they feel are necessary for themselves. I think, but that's true all the time. Again, this is the first time we've dramatically changed that. And I'm a little taken aback by how quickly a large segment of society allowed it and encouraged it. And I just find that so interesting. I got the most interesting question on a radio show yesterday, and it went something like, okay, we make people stop at stop signs, so why can't we make people wear masks? And I get that at first that sounds totally reasonable, okay? But let's think about it this way. One, if you run a stop sign, there's almost a guaranteed consequence. Okay, so that's one difference. There is no guaranteed consequence by not wearing a mask. Okay, with a disease that it's not clear you even have, that's not clear you could transmit if you had it, and it's not clear the mask would help, and it's also not clear that it would even affect the health of anybody around you. It's also true that you'd be voluntarily. Both parties in that situation would be voluntarily interacting. So those are a couple things. Running a stop sign arguably has a more direct consequence. Also, we've spent a lot of time crafting that law. Also, that law was created by a democratic process. And it was meant to mitigate a risk that we adapted to over a long period of time and eventually agreed upon as a society. All of a sudden, forcing somebody to wear something on their face, which they didn't have to just a few minutes ago, I think is wholly un-American. I'm all for the guidelines, and we bought 50,000 masks to hand out to low-income neighborhoods in Houston. But the idea of fining somebody or throwing somebody in jail because they're not doing your guidelines, I think was such a huge overreach, and it really demonstrated to me that our leaders have lost a sense of what it means to govern, a sense of civics. They've not been educated on basic civics or basic political theory. And I find that to be very problematic. That's my take.
Well, and I think it gets back to your point about common sense and the American people. And I think that's where we really need to focus on as we go forward. You know, the president's made some, in terms of reopening America, one of the things that we haven't talked about yet, what I'd like to is just saying what we're trying to do, an initiative called Warp Speed, which is really how do we make safe, effective vaccines faster. It's kind of a Manhattan Project. It's really bringing together a dream team of civilian and government workers together who are experts in this field to basically do something which is feasible, we can do this and really do it and we joke about it as Trump speed, Trump time, being able to do this in a way that would basically...
Half the country won't take it if you call it Trump speed vaccines.
I understand. But the point here, though, is how do we basically do something that really is unprecedented in some other ways to advance science and our means to protect ourselves? Because this won't be the last time our nation, humankind, may have to encounter something of this nature. And so I think one of if you want to talk about the silver lining of this, is really trying to figure this out in a way that would give confidence to the American people that they can get vaccinated, protected from this, their family can be protected from this, and we can get back to being Americans, back to business, back who we are.
So what is the status of Operation Warp Speed? Is this going to be the fastest we've ever come up with a vaccine? What's your thoughts?
Well, I think it can be, and I think the likelihood is we have a gentleman, and I think it's worthwhile just to spend a minute or two talking about the people who are involved in it, because this is a consortium of not only the whole of government, but the whole of nation. So the chief scientist in all this is a gentleman called Moncef Slaoui. He was formerly the head of vice president for GSK for vaccines. Extraordinary, talented man. He has personally been involved in developing and approving 14 vaccines by the FDA. And he's kind of like the big head, if you want to call it there. General Perna, who's a 4-star general, the chief logistician for the Army, someone who's going to retire, who stayed on to basically do this task. And I should say Moncef Slaoui was also retired, came back to serve his country, literally. And then a third gentleman by the name of Carlo Di Notari Stefani, who's really the manufacturing person, 37 years involved in private sector manufacturing of pharmaceuticals. That's just the tip of the spear of, I would say,
that's
the
in
people.
the government side, right?
Two of them are civilians who come in, are experts.
Right. But they're playing it in a government role, just overseeing the sort of Operation Warp Speed. Because, I mean, obviously all the development, the research, this is happening from private sector.
That's correct.
Okay.
And basically we're trying to guide, coordinate, and accelerate the way we do this. And it's really extraordinary.
Well, that's good to hear. Is there any new news that we'd be hopeful to hear about, or you don't want to say anything?
I would just stand pat on the idea that we have the best minds and hands working this right now. I think they're going to be working through the summer to do those clinical tests, to evaluate these products, to make sure they're safe and efficacious, doing not only animal testing, but also looking for safety in humans. And then what we're doing that's different is while we're developing these vaccines, we're actually manufacturing them. Yeah. And so we'll have a stockpile of vaccines by the fall that we can use. And that may be more than one vaccine, which is great. It means more vaccine for Americans who want it.
The sort of dream team that you outlined for the vaccines, do we have the same kind of thing with testing?
That's correct. We set up the same, there are 3 lines of effort for therapeutics, for diagnostics, and for vaccines.
Yeah. Okay. What about on the therapeutic side? Are we making progress there? Is there some promising things?
There are some promising things, but again, like everything, it's got to be tested and evaluated.
Right.
Therapeutics represent, you probably heard about hyperimmune plasma, where basically you take convalescent serum from people who've been sick, and that can be life-saving. The challenge, maybe the good, bad news here is there are a lot more people who've been sick, and that provides an opportunity to get their serum that could help other people who need it, as well as using monoclonal antibodies and small molecules. So all of that, and by the way of a dream team, Janet Woodcock, formerly of the Centers for Drug Development and Evaluation at FDA, is leading that effort. No one more competent, experienced in doing that is leading the nation's effort. So we're blessed to have all those people working together under this umbrella of warp speed.
What do you think about all the drama over hydroxychloroquine?
It's a lot of drama. I mean, I think, it's like everything else there. It's been a drug that's been used widely for a variety of circumstances, rheumatoid arthritis, lupus, even for things like malaria. It is a drug that, interesting enough, anecdotally, I've heard from people who've taken it. They say it's a miracle drug. For some others, it may not be. Clearly, I think the key thing here is what we've sponsored at ASPR as being the Assistant Secretary, focusing on testing these things under random clinical trials, places in New York and Detroit and other places around the nation, to evaluate them and to see what the benefit is. The benefit may be early use in people who are not hospitalized, and that may be the circumstance.
Yeah, we still don't know.
That's right.
The media says it'll kill you. President Trump says, hey, it might help you if you take it early. I mean, he's taking it early. I don't think his doctors would tell him to do that otherwise. I think the drama behind the entire thing was patently unbelievable. I mean, it's we in the military, we take these malaria drugs overseas. It's perfectly safe, and it's just so strange, the things that have gotten politicized during this whole debate. I mean, America gets a big F for it. I mean, let's just be honest. We all need to do better.
So as a combat veteran, I have to ask you something. I've always kind of experienced. I've been involved in 2 conflicts in my career, and I always felt like I knew I was at war when I just saw the absurdity of certain situations. And again, the absurdity of this situation has that kind of feel to it, right?
Yeah.
Where things are just exaggerated to the nth degree. So the absurdity of some of these issues, as you identified, just kind of reaffirmed that in some ways we are at war, sometimes at war with ourselves more than we were the virus.
Oh, far more. Far more. I mean, you know my opinion. We made it far worse than it had to be. And we let emotional reasoning take over. And the hydroxychloroquine debate was just that. There's way too much anecdotal evidence, especially when you combine it with zinc or the Z-Pack or whatever else that there was in that little COVID cocktail, as some doctors would call it. So much anecdotal evidence that it works well that it's hard to dismiss it. Clinical trials are, of course, needed. I mean, I just don't know why we can't shrug and say, hey, we don't know, but it's worth trying. I mean, I don't know why. Why would you even have more of a conversation about it than that? Well, I know why, because the president liked it, and therefore we have to make it political. And I just thought that was it's such a smudge on America's character when we do things like that, and our media does things like that. And I wish they would stop just this once. And stop with this nonsense, because it's just, I'm sure it's incredibly frustrating from your position when you guys are really just trying to solve problems and get this thing moving forward. But you've got to deal with this sort of storm outside which is just fueled by anger and emotion. You wanted to talk about the National Stockpile too, and I think help people understand what's in this thing, how it's managed, and maybe how we can do better next time. One of the biggest things that everybody knows about that was missing from the National Stockpile was N95 masks. Mm-hmm. Those were depleted after H1N1, as I understand it, and they were never replenished. I've noted this before when everybody wanted to play the blame game with the administration, and I thought that was, again, silly nonsense, and so had to fact check a few people. But I also don't necessarily blame the Obama administration. I'm not sure that they had a crystal ball that said, hey, we're clearly going to need N95 masks in this pandemic in 2020. And so how are those decisions made? You can't obviously stock it with everything under the sun. Sure. So how should we be thinking about this? Sure.
Well, I think it's important for the listeners to understand that the origins of the stockpile, which was originally the National Pharmaceutical Stockpile, created in 1998 during the Clinton administration. And it was really based on the concern about bioterrorism. And obviously after 9/11, that the concern about terrorism grew, and so did the stockpile in terms of our stocks of specialty medications that really don't have a commercial market.
Right.
Things for anthrax, things for smallpox, things for Ebola for that matter. And so really that was the preponderance of the focus through the 2000 era. And then in 2009 with H1N1, it became also saying, well, we should have some element of, pandemic preparedness in that. And so there was a quantity of N95 masks in there. There were some studies that were done in 2015 during the Obama administration that looked at what would be necessary for a pandemic. And quite frankly, there was a study in 2012 that said, what do we need to have for a stockpile in 2020? And what it was money. It was basically investments of upwards of about $1 billion a year.
Yeah.
Well, the investments were about $500 million a year to maintain the stockpile.
Which is still a big increase from like 5 years ago, right? I mean, it's, we've only got so much money.
True, but I think the thing is, if you sized it for what was needed. Yeah. Now, but the thing is, the fallacy is that you're saying, well, this is a federal government responsibility. Mm-hmm. And when you find out, it's really everybody's responsibility. It's healthcare institutions, it's states that have a responsibility. So I think with the Strategic National Stockpile 2.0, which the president has announced, is really looking at how do we kind of share the responsibility so that's just not the federal government doing this. Right.
It was this absurd belief, and this gets to the improper understanding of the role of the state and the federal government. I would talk to hospitals in Houston, and they said, we've never really had this PPE problem because, we heard about this thing in China, and so we ordered a bunch of PPE. We did it ourselves. So of course, why wouldn't you? And by the way, hospitals do get money for this specific kind of expense, right? There's grant programs that specifically allow for that. So, the question is, that's maybe a question for Congress to be looking into, is what exactly happened to I forget the actual terminology for that grant money. What is it?
Public health emergency preparedness.
Yeah, exactly. And so, what were hospitals in New York spending that on? I mean, that's a fair question to ask. What was Governor Cuomo spending that on? I mean, if we take New York City out of the equation when it comes to U.S. numbers and total cases and total deaths, we start to look like one of the least hit hard countries in the world. And I think that matters, and then again, just hindsight's 2020, of course, but we have got to rationalize our thinking just a tad so that we don't do this again. But on the stockpile stuff, so, these Houston hospitals were well prepared because they took it upon themselves to actually prepare. And you have to encourage that kind of behavior. There's this strange thought that every time something happens that the president on his horse is going to come swooping in with the federal government. And that's an absurd belief. It's not accurate.
Well, can I tell you an anecdote? Because it was early in my tenure, actually on day 5 of my tenure, when I was notified that a little hurricane called Harvey was heading towards Houston. Mm-hmm. And I actually got to go down to Houston right after that happened. But one of the things that was extraordinarily indelible in my mind was how well prepared Texas was and how well prepared Houston was based on the experience they had with the floods, that they had taken some of this preparedness money and actually kind of made their hospitals more resilient. Yeah. Great stories about places like Ben Taub and other hospitals. There was one in Beaumont, Texas that didn't have to build resilient waterproof doors, but what they did is they bought flat-bottom boats and hip waders because they knew the hospital was on the high ground, and when it got flooded, that they could basically retrieve people. This was the Cajun Navy story. Yeah. But I think the thing is what we saw from Texas and C-Track, which is kind of like their manner by which they work to basically organize their hospital preparedness program, was something that we duplicated with our regional disaster health system in other parts of the country, in Nebraska and Massachusetts. But realizing that many states, Texas in particular, Florida is another one that really has thought through these issues. They've had experience, obviously, but they made the right investments. They bought the right things, the PPE, and they were able to mitigate that. That's the kind of, I think, what it's a shared responsibility we need to develop. And I think that's really what SNS 2.0 is all about, is really how do we basically get everybody involved. And that's not only the hospital systems, but that's industry, making sure they have surge capacity. Just as an anecdote, in January, when we realized that we may need to buy PPE, we went to the major distributors and there was none. Because guess what? China was buying it all.
Yeah, and hoarding it and not allowing it to be exported either. Last thing before you've got to go is, last year we actually released the National Biodefense Strategy. Can you explain? So we had this strategy. How much did we stick to the strategy, and what should probably change about the strategy now that we've experienced COVID-19?
Well, it's interesting, the strategy, which is unique, in terms of a comprehensive strategy that President Trump signed, and then subsequently basically published an executive order about a pandemic influenza. It's prescient because it recognizes this kind of potential event, and said this was something that we have to be prepared for in the future. Now, little did we know that within 2 years of that document that we would be experiencing that, but it highlighted several areas that I think that are noteworthy. One, I think you just highlighted with the personal protective equipment issue. We have to have domestic resilience. We can't be dependent on China or other countries for these products, whether they're pharmaceuticals, whether they're N95 masks. And by the way, these guarantee American jobs and American opportunities on our shores. So we need to reshore things, number one. Number two is we need to have a system that is comprehensive and fast. We have to have a national testing system that we didn't have. Recognize that. We also need to basically move quicker in terms of our means to develop drugs, vaccines faster to meet the need. So in some ways, and again, part of the strategy was to do an assessment. The year one was an assessment of what we've been doing and recognize we've been doing some but not all. And then the president signed the pandemic influenza executive order to identify that gap if you want to look at it. And then obviously now we have the COVID event, which identified other gaps, and we're trying to fill those either with executive orders or with activities. So it's been a real learning experience in some ways, but one that I think was recognized. Now, here's where Congress plays a role. And I've made this statement several times to your colleagues here during Appropriations Committee's hearings, is because one of the facts that came out of the assessment was saying, how much are we spending on this problem? Well, it was $6 billion. And, and as I commented, that's half an aircraft carrier.
Yeah.
And this investment is an insurance policy to the future of what we're now experiencing, which is costing us trillions of dollars in the economy, in people's lives, and lives lost. So maybe that will be the ultimate wake-up call to say, we have a blueprint.
Yeah.
We probably didn't get far enough down the road to execute that blueprint, but we've certainly got enough of, if you will, the lessons observed. We don't know if they're learned yet, but to basically do things as we're doing right now to address some of these shortfalls.
What would that look like? You said a national testing infrastructure. What would that look like in practice? Are we sort of there now, or how would that look, and how do you anticipate what that test is going to be? Because the next pandemic is different.
Yeah, well, I think the thing is so have you ever heard the NERC and the FERC, which is the Federal Energy, gosh, I'm blanking on the commission, but basically it's how the private sector organizes itself. And so, we're a federal government, but really the majority of healthcare resides in the private sector. And so really, in some ways, I think it's the requirement of the private sector to organize itself, the laboratories, just the commercial laboratories, the private hospital laboratories, and the healthcare systems as well, to basically organize themselves to work more efficiently and effectively together. Because the government is not always the only answer in the book. In fact,
well, we were in the way of testing, and then we got out of the way, and then it did appear to happen pretty quick after that.
Right.
Now, I guess the question moving forward, and again, I'm very skeptical of just increasing amounts of tests. It seems to me that if we're going to move forward, that a national testing infrastructure would look something more like an idea of who gets tested and where and why. Because I think that question has been left largely unanswered. Shouldn't we maybe we should be providing tests to, instead of saying, hey, there's tests in this parking lot, wait in a line and get them. Well, sure, but
there are better ways to do it, right?
Yeah, well, yeah, maybe have allow businesses to test their employees every once in a while to especially if you work in a big factory setting. That would seem to make more sense. Or schools test. I don't know. There seems to be ways to make that would be more efficient.
And by the way, I don't think that's a government answer there. It needs to be done by local communities, like you said, schools, and quite frankly, sharing the data becomes very important as well. So I think some of this is not only whether you test this, but how do you basically share the information so that the public and industry can benefit from the insights that are learned from it.
And is it those kind of lessons that we can expect in the a new iteration of the national biodefense strategy?
I think that's something that Ambassador Birx is working on right now as we speak. So I think the thing is that there are a lot of changes in movement right now. We talked about, the Strategic National Stockpile. We talked about some of the laboratory testing. We talked about data sharing. And these are major muscle movements. But I think in the end state, again, it's really getting back America to work, get back kids to school, get back to business, getting back to be Americans, and quite frankly, to the society that we know and love and defend.
And so, from a doctor's perspective, and your specialty is in tropical diseases, I think, right? So you know a little bit about this stuff, and you're comfortable with the idea of reopening. I mean, you think it's time, and that we can mitigate risk accordingly and trust Americans to go at it.
I think most definitely. You give people good information, and they use common sense, and they know how to protect themselves. They're the best person to protect themselves and their families.
Yeah, it's in their interest, yes.
It's in their interest, and as is the fact that they need to make a living, they need to put food on the table, and I think those are all parts of this. Yeah.
The last question I wanted to hit you with was vaccines. Is there a biodefense strategy in the future where where BARDA can be more prepared with vaccines, or is it even possible? I mean, can you make a vaccine for something you haven't seen yet?
Well, that's a great question, and I think that's the issue is so for example, I'll just use this as example, SARS came out in 2003, and there was an effort to basically make a vaccine there, but there was no investment from the private sector to do that. Could that have been a government activity? Could have been, but it wasn't. And so there are classes of viruses. We know that the hemorrhagic fever viruses like Ebola and Marburg, that's something that, quite frankly, as a result of those two outbreaks, we're well down the path, and we have an FDA-approved vaccine for Ebola, and arguably we could do it for those other hemorrhagic vaccines. So there are investments that are strategic in nature, like with pandemic influenza, the universal flu vaccine, that do make a difference. Now, do they have commercial value when you don't have a pandemic? No, but I think that's an extraordinary role for the government, witnessed by this event, that having a coronavirus for the next coronavirus event could be very helpful.
Well, I mean, and my question is, scientifically, is it even possible? Can you make a sort of baseline coronavirus vaccine that, is easy to tailor in a matter of months for a new coronavirus outbreak?
So one of the strategies, the answer is simply yes. One of the strategies is building platform vaccines. So, for example, the vaccine that was being used for Ebola that Merck made, VSV, vesicular stomatitis virus, VSV, is basically worked for Ebola and is now being tooled for COVID, for this coronavirus. Same thing with the Janssen vaccine. Same thing with one of the Oxford vaccine. And same thing with Moderna, is that you can use these platforms to rapidly produce it. Now, one thing you could do is rapidly produce it. Moderna was the first out of the gate by taking the genetic sequence from the virus in China without the viral samples and actually making it into a prototype vaccine. And so that's the one that's going through phase 1 studies now. And so the thing is you can do that. What we need to do is, do that faster and more compressed. And that's really what Warp Speed is about, is really trying to make it a much more efficient. It's not a sequential activity. It's really kind of doing it in a much more coordinated, we call it stacked approach, without giving up safety and efficacy to protect the American people.
Gotcha. You said an hour, so I'll keep going if because I want to talk more about reopening, but
sure.
But yeah, what is your
reopening? I mean, I would love to talk more about reopening, because I think that, again, the president's kind of put a bold agenda out there, and he said, look, with vaccine or not, we're going to go back to business. Yeah. And I think it really represents maybe what is collectively what your point is as we learn more about the virus and learn more about that the fatality rate is low for the general population, and we just need to protect the vulnerables. We can do that, right? I mean, we put a man on the moon. We can do that, and with testing of nursing homes and personal protective equipment at nursing homes and all that stuff. And so those are the things that I think are practical realities, because we are in this situation now where we could basically cut off our nose to spite our face, and our faces.
We have
yes,
smashed our face into the wall like 15 times. and it's devastating. And it just, and that's okay. You know, it's okay to have made a mistake, to maybe have stayed locked down too long. I think there's a lot of justification for that, for an initial 2 to 3 week lockdown to accomplish two very clear goals: don't overwhelm our hospital system and flatten the curve. But it was pretty obvious at a very early point that those goals were accomplished. And then the goalposts started moving. And I'm just wondering, like, when we look back in hindsight, knowing what we know now with the data that we have now, I don't see at all how we can justify multi-month lockdowns. You know, it's never before have we said never go outside until it's safe. Well, it's never safe. You know, this is planet Earth we live on. Mother Nature's always trying to kill you with something, or we're trying to kill ourselves with, like, you know, dangerous driving down the highway at 80 miles per hour. If I didn't want 40,000 people to die every year, I would just outlaw cars. I would just outlaw them. I mean, do you really need them? You know, you could have a horse, right? There's other ways to travel, I suppose. Maybe we should force everybody onto trains. I think that's slightly safer. I mean, it gets to be ridiculous. You know, we live with risk and we learn to mitigate it. And as we've learned more about this disease, I mean, the data just doesn't compute. And I want to ask you too, because I've long had frustrations with everybody's obsession with peaks and curves, and as opposed to looking at the numbers underneath that curve and how it relates to hospital capacity, which would seem to me to be the only numbers that actually matter. So Governor Abbott in Texas, when he talks about this, those are the numbers that matter to him. Right. But unfortunately, when I hear from some local officials, like my own local officials, and others across the country that have just, I mean, I think completely inept and incapable of basic critical thinking. You know, that's the kindest I can put it. Sorry, which wasn't very kind, but I don't care, because it's hurting people. And you know what? Like, the time for niceties is over. But you know, an obsession with the curve, and they'll say something like, well, we haven't hit our peak yet. Well, you don't know when you've hit your peak yet. And what if it plateaus? And what if it plateaus at like 150 people per day? According to CDC guidance, you should never reopen if your numbers plateau at, say, 100 new cases a day, even if you're in a city full of millions of people. Okay. Now, but according to that same guidance, 14 days of a decrease in cases, you could say that, well, we had 50,000 cases today and 49,000 cases tomorrow, all the way down to 36,000 cases in 2 weeks. And all of a sudden, what? It's like free for all? I mean, it doesn't make any sense, you know? And so I have seen so many, I think, politicians thinking overly simplistically about this. And in hindsight, I just can't believe that we're still doing it, because we know better by now. That's my thoughts.
Well, but you know, you raise an interesting point, which to me has always been confounded by the data. And first of all, your point is the real numbers matter most, right? Mm-hmm. I talked about the Diamond Princess; those were real numbers, and that was kind of like the worst case scenario you could look at. But I think some ways, you know, it's hypnotic, I think, almost, where some of these models and these peaks get all generated, and people lose the sight of, you know, not only what's behind those numbers, but the fact that, you know, we closed down elective surgeries or cancer screenings.
Right, the consequences. The
consequences of this is just, it's unbalanced. And I think that's one of the critical things that people have to kind of accept, that, you know, we can't survive this if we just, you know, hunker down. Again, it's like I said earlier, it's un-American. It's un-American to just to be hiding in your basement and you know, hoarding toilet paper. I mean, that's just not what, you know, we're all about.
You know, we live in a free society of voluntary risk acceptance. And that's an important point, you know, because when you're accused of being a murderer for letting people go back to work, and it's like, wait a second, I'm not forcing them to go to work. You know, if you want to call me a murderer because I said we're going to go on this mission in Afghanistan and I'm going to make my guys go with me, I mean, fine, I guess. At least I'm making them do it. You know, I'm giving them the orders to do it. Now, they also volunteered, you know, to join the military, all of that. But the point is that we never talk about it that way. Nobody would ever call you a murderer because you lead your men on a dangerous mission. They would never call you that, even though there's a high risk involved with that. But all of a sudden, you're going to call people murderers. The media's, and they do. I believe one headline from The Atlantic was something like Georgia's experiment with human sacrifice. I mean, it's so over the top. It's insane. It's absolutely crazy. Okay, so I bring up that one headline just because there's so many like it. Like I'm not exaggerating here,
right?
And I'm not talking about the fringe left. I'm talking about politicians. I'm talking about leaders and media leaders. I never reference the fringe. You know, when the left talks about the right, they always reference the fringe. You know, it's like, oh, the right's saying this. The right's like refusing to wear masks. It's like that's not. No leaders have said no, refuse to wear masks. We just said you can't throw me in jail for it. Okay, that's right. You know, that's the point. But you would never call somebody a murderer for saying, I want to allow people to live their lives. Again, not forcing anybody. If you don't want to go to a restaurant, don't go to a restaurant. You know, last time I checked, that's like not obligatory. You don't have to go to a restaurant. Now, I highly encourage it because they need your business, everybody. But I'm not going to force you. And if you want to stay sheltered in place, you are perfectly welcome to do that. Maybe you're lucky enough to have one of these telework jobs. You know, and I think that also has a lot to do with who's in favor of lockdowns and who isn't. For a lot of people, this is kind of an interesting new life for a few months where they just work from home, and it's, you know, they get a little stir crazy, but like that's their biggest issue. They're stir crazy. And then they, you know, and then they'll shame other people who are losing their jobs and businesses who are mad, and they, you know, storm a Capitol in whatever state they're in. And they're like, guys, I know we're all getting a little stir crazy, but you need to calm down. Well, no, it's not stir crazy that these people are worried about. These are real problems they're having, you know, and even no matter how many trillions of dollars we spend of your money, by the way, at the federal level, it can't fix their problems, their dignity, their life is completely disrupted. And as they are smart enough to learn more about the virus, how it spreads, how deadly it is, how it probably won't even affect them, they have a right to question what the heck we're doing, you know, and they have every right to question it. And I'm just repeating myself by this point, but I'm fired up by this stuff. I'll tell you what.
I don't blame you. It really does kind of, you know, go beyond pale when you think about what we're doing at this point and what we need to be doing, right? Yeah. For Americans to get back to what they, you know, want to do and give them reasonable guidelines. They're smart enough to do this, and that's what's crazy about it.
And there was a lot of goalposts, I think, that we set. You know, hey, we don't have enough testing, so we can't open yet. And we were all kind of in agreement with that. But then we have like way too much testing. Okay, we have way too many ventilators. What are we doing with all these ventilators, by the way? I don't know. Maybe we'll sell them. Maybe we'll make a huge profit. Because we had more per capita than every other country. I did some math on this. We had more per capita in ventilators than any other country prior to the pandemic. Now we have like the most in the universe, right? I mean, which is great. I'm so happy about that. We have a great amount of ventilators.
And we're making good use of them, by the way. The president's been gracious in offering them to other countries that need them.
We are going to give them to other countries. Okay.
Well, I mean, but I think it's
might as well.
I think they're going to buy them from the ventilator companies. Yeah. So the virtue of what we have procured is going to be purchased. And
can we upsell them to China for some huge amount?
Well, ours work, and I don't know about theirs.
Yeah, well, exactly. Maybe we can make a profit. For once, let's take advantage of the Chinese. That's a whole different story about maybe for another podcast. But I guess my point was, you know, we hit our marks, right? There's plenty of testing to go around. There's plenty of ventilators to go around. It seems our hospital space is adequate now. And so, and I'm not going to criticize the federal government too much on this, because it does seem like those facts aligned with the guidelines coming out of the federal government. Are you in conversations with state governments? Do you have these conversations and hear their fears? And why do they make decisions that are so that you would argue are just wrong and maybe too draconian?
You know, one of the challenges I do speak to state officials. Occasionally, I speak to, you know, listen in on governors' calls, and I speak to the state health officers. And I think from the standpoint of what I perceive in some of these conversations, and I had one as recent as yesterday, is that the risk that sometimes they're trying to mitigate is the political risk rather than the public health risk. And I think that's the veneer that gets that gets ladled on, that basically I think creates the distortion of what I think, you know, Americans would want to know is like, tell me, you know, I don't want to mitigate your political risk, you elected official, whatever the county, state, whoever that is. But I want to know what I need to do to mitigate my personal risk.
Right.
And my personal risk is not only my health, but it's my economic welfare and it's just my mental health as well, and my child's future going to school or not, and all those other things that factor in everybody's everyday's life.
I think that's right. I think it is political risk, but I also think that's backfiring for a lot of these people who made those decisions, because I think they're finding that people see right through it, and that they wake up one day and say, "Hold on a second, you don't need to control my safety. You can give me the tools, and I appreciate that. That's what government's for, to support underneath, but support the freedom of the individual, and let us engage in that freedom." So I think that's a good place to end it there.
Well, I just appreciate this very much, Congressman, and what a pleasure to be back, and what an honor it is to kind of share this conversation with you, and privileged to serve as well.
Well, I really appreciate all the work you've been doing behind the scenes. It's good to let people know about that, or maybe, I don't know, hopefully that goes well for you.
We'll see.
Yeah.